Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. Patient had a Panoptix IOL and was complaining of visual disturbances. And despite optimizing his surface, making sure everything looked good, the macular OCT was fine, there's no visual field abnormalities, this patient still couldn't see very well. He's having poor quality of vision. And so the decision was made to perform an IOL exchange. The patient had surgery about 6 months ago. And so we had a long discussion about the fact that he's going to be losing something. He's going to be losing his near vision that he has by replacing with a monofocal lens. Plus, he had a toric lens as well. He elected to just go ahead and switch it to a monofocal lens, and he was resigned to the fact that he'll still have to wear glasses. I'll make my paracentesis incision first on the right side and then the left side. I'm injecting some intracameral lidocaine, and this is some dispersive viscoelastic. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then using the cannula to control the eye, I enter. And this is a hypodermic needle, about a 25 or 27 gauge needle with some viscoat. Bevel down, I go ahead and get underneath the rexus edge, and I start pushing the viscoelastic to create a little bit of separation between the rexus edge and the lens. I switch back to the cannula, inject some more viscoat underneath the edge of the rexus. But as I do this, you can see there's a sudden explosion of air that goes underneath the lens. Here it is in slow motion. And it was a pretty abrupt air bubble there. So I was really a little bit shocked when it happened, and then I kind of gathered myself. The good news is the posterior capsule didn't blow out with this maneuver. And so I'm like, okay, how am I going to get that air bubble out? It's underneath the lens and the rexus has captured it in that space. The good news is the posterior capsule is intact and now obviously have good separation between the posterior capsule and the lens. So I decided to use a Sinskey hook to just bend the edge of the lens, and it pops the bubble right into the anterior chamber really nicely there. Go ahead and take the bubble out, and then I'm going to go in and circumferentially dissecting the anterior and posterior capsules. Coming from the other side, doing the same thing, trying to create some separation between the anterior and posterior capsules. Go through the other incision and do the same thing, trying to go into the subincisional area, and very carefully pushing the viscoelastic. You want just very careful amount of pressure. You don't want to apply too vigorous pressure when you're doing it this way. And of course, the area of the haptic is going to be the most stubborn. So you want to make sure you really get good dissection, visco dissecting the anterior and posterior capsules off 360 degrees. Once I've done this, I take the cyclodialysis spatula and I'm sweeping all the way around, making sure that the anterior capsule is off of the lens, as well as off the haptics here. And now I'm going to use a Sinskey to gently lift up the lens. And I'm doing this just to really kind of assess how loose it is. And thankfully, this haptic on the left side comes up out of the bag pretty easily. I'm depositing it right into the angle there. Try to do the same thing on the right side haptic. It's a little bit stuck, the tip is a little bit stuck, but then as I pulled it, it came right out. So these are micro forceps and scissors. In my left hand, it's the serrated forceps. I grasp the lens. You can cut with the scissor, but it also holds the lens. So as I'm cutting it, I can always reposition my forceps in my left hand as I'm cutting it. So I bisect it completely in half. Grasp the lens with the right forceps, grasping the haptic, externalizing the haptic, instead I just go ahead and grab the optic, making sure that the lens doesn't touch the cornea. You can see the haptic folds on itself. And then it comes right out. With the teeth closed, I lift the lens up with my left hand, grasp the edge of the optic with the right hand, protect the cornea with the left forceps as I pull out that second half of the lens. This is a 2.4 millimeter incision, so I'm very slowly but carefully letting the lens collapse on itself and then come out. This is cohesive viscoelastic to fill the bag. Very important that you don't overfill the bag in these cases. The capsule can be delicate in these situations. I'm injecting the single piece acrylic intraocular lens into the capsular bag. I'm making sure both haptics go into the bag nicely there. I go in with irrigation off, activate irrigation, go under the lens, remove all the viscoelastic from within the bag. Remember, the viscoelastic within the bag is a mixture of dispersive and cohesive viscoelastic. So you want to make sure you get all of that out. I put the lens back in the bag, polish underneath the rexus edge. I'm rotating the haptic and then removing the viscoelastic from within the anterior chamber. I'm going to continue to rotate the haptic in a horizontal direction there, and then remove the viscoelastic from the anterior chamber again, and then I'll hydrate my incisions. So again, this is a patient who had a Panoptix lens. It was actually a Panoptix toric lens. The patient was having quite a bit of trouble with the quality of vision with the lens. They tried to optimize the surface of the eye and try to treat anything that might be undermining his quality of vision. Ultimately, it was decided that his quality of vision was just too compromised, that he resigned himself to going back to glasses, and we switched him to a monofocal lens. And he does travel from a little bit far away distance, and so I did see him most recently. It's a couple of weeks after surgery, and he was quite happy with his vision. Even without correction, he felt like the quality of vision was better with the monofocal lens. course, he was correctable to 20/20, so he'll get some glasses for that. So this is a standard technique on how I exchange a lens within the bag. I use a 27 gauge hypodermic needle with Viscoat, go underneath the edge of the rexus, create some separation between the rexus edge and the lens surface. Once you get in there, you can go in with the cannula and create some space between the anterior capsule and the lens, and you can continue to visco dissect into the capsular fornix even more to separate the anterior and posterior capsule. You do this 360 degrees very carefully without any excessive force, and then switching to the cyclodialysis spatula, making sure it's really separated well, prolapsing the lens up with the Sinskey hook, making sure there's no adhesions, and then using microforceps and scissors, bisecting the lens, taking it out, and then putting the new lens in. So I hope this was helpful to you, and I thank you for your attention.